Going back 6 months ago, most people had never heard of a pandemic. Our team had been prepared for this right from the beginning. The hospital was actually built with this in mind, although to be honest, we never thought we would need it.
On est prêt depuis déjà des semaines et on va faire de notre mieux pour prendre soin de nos aînés.
Quebec has reported over 14,000 cases and 435 deaths.
Coronavirus can affect anybody. Stay home, don't become a statistic, and stay safe.
Il ne faut pas lâcher.
From the beginning of the pandemic, I've been really blown away with the collaboration between our donors, the hospital, and the foundation. Everybody just wanted to help.
So, keep home, stay safe, keep each other safe, so we never have to live the nightmare that we see on TV.
Thank you so much for everything you're doing for all of us and all of you.
Vous avez ce don. Merci.
You make all this possible and more.
Réalisez des merveilles, vous avez ce don.
Bringing hope and healing, you have that power.
Supporting our hospital heroes, you have that power.
Thank you, JGH. Whoever comes to work every day is a superhero.
Les gens qui travaillent à l'hôpital général juif, les médecins, les scientifiques, les chercheurs, le personnel qui travaille dans cet hôpital est absolument exceptionnel.
Shukran jazilan.
Fueling our frontline workers with over 25,000 meals and snacks. You have that power. Thank you.
Our team is here making sure that the air that you're breathing is safe, any surface that you touch is safe, and they're here 24 hours a day, 7 days a week, making that possible.
Rapidement transformer l'hôpital pour mieux dépister, traiter et contrôler la COVID-19.
Réinventer la prestation des soins de la santé. Vous avez ce don.
Investing in state-of-the-art equipment and facilities. You have that power.
Concevoir de nouveaux outils numériques pour identifier les personnes âgées à risque. Vous avez ce don.
Bringing communities together. You have that power.
Building the largest biobank in Canada to get big data working for us on real solutions.
Ensuring the continuity of mental health care during this crisis and beyond. You have that power.
Developing advanced analytics to allow the JGH to respond effectively during the pandemic. You have that power.
Prototyping the first 3D printed ventilators in Quebec. You have that power.
Leading the way to extraordinary patient care. You have that power.
If I'm alive today, it's because of them. And if I can actually look into the future, it's because of them. It's that simple. You have that power.
Today and for tomorrow.
Merci beaucoup.
Shukran.
Grazie.
Dhanyabad.
Merci de fond de cœur.
Thank you.
Grazie.
谢谢.
Voilà.
Thank you. Merci.
Muchas gracias.
Dhanyabad.
Merci beaucoup.
Grazie.
Thank you.
Toda rabah.
Nous avons tous l'opportunité de prendre soin de ceux qui ont pris soin de nous et merci à ceux qui ont pris soin de moi.
Good afternoon, bon après-midi. On behalf of the Jewish General Hospital Foundation and our board chair, Harvey Levinson, it's my great pleasure to welcome you to this important virtual Parlour meeting. We are thrilled to have over 240 participants for this meeting this afternoon, and more people keep joining every minute. You've just seen the video which pays tribute to both our donors, to our COVID-19 campaign, as well as to our frontline heroes here at the Jewish General Hospital. Today we're going to talk about how sometimes we forget about the impact that COVID has had on our non-COVID patients, and we're very anxious to hear from our panel of experts coming up in a moment. Just a little bit of housekeeping before we get started. You'll see on the bottom of your screen, if you move your cursor, a Q&A bubble. That's where you can type in questions that will be reviewed and brought forward following the presentations. And of course, we do ask you to not post personal questions related to personal medical situations, but rather more general questions for our physician experts with us today. Et les questions peuvent être posées en français ou en anglais, évidemment. Questions can be asked in the Q&A box in English or in French. So without further ado, I want to introduce our moderator for this afternoon, Caroline Van Vlartigen, who is an anchor reporter for CTV News Montreal. Caroline, over to you.
Thank you, Bram. Merci tout le monde et bienvenue. Ça me fait un grand plaisir d'être avec vous aujourd'hui. As a journalist, of course, I've been covering COVID-19 since the beginning and watching the tremendous efforts and work of researchers and doctors and people in the healthcare system who have been saving so many lives. So many questions still that we're facing as children now head back to school. And I'm sure you have many of them. So please keep those in mind as we hear from our esteemed colleagues or our esteemed doctors at the Jewish General Hospital today. With us, we have three high-ranking researchers and doctors in three different areas. The first, Dr. Gerald Baptiste, will be speaking about the impact of COVID-19 on the Cancer Center and the patients at the Jewish General Hospital there. Dr. Lawrence Rudsky will be addressing heart disease and COVID. And finally, Dr. Carl Looper will speak about the parallel pandemic of mental health issues along with COVID-19. So without further ado, let's get right away to Dr. Gerald Baptiste.
Thank you. Thank you very much. It's really a thrill to be with all of you, so many people joining us on this webinar. As we all know, COVID has torn people so much apart, but during the worst part of the pandemic to date, we've also seen paradoxically how it's brought people together. And for us at the hospital to have our supporters and people who we know are connected with the hospital by virtue of personal experiences, supporting us like this is extremely important. As you know, the hospital was a frontline COVID hospital and therefore received many of a large number of the patients from the very start. COVID, as horrible as it is, and it's a pandemic that is still with us, we should not imagine that it's over, has also strangely brought facilitated some changes. So I'm going to talk about that with respect to the cancer mission. We have essentially three missions in the Siegel Cancer Center in the context of the COVID pandemic. The first is to protect our patients and staff from contracting COVID. And from the very beginning, from the reports at Wuhan and in Italy, we already started to see data that cancer patients were at increased risk of catching the disease and of having a worse outcome if they did catch the disease. So we felt particularly protective of our patients. And I'll describe some of the things that we've done to limit their exposure. Secondly, because the hospital was a frontline COVID hospital, there were enormous pressures on the system. And so we needed to ensure that our patients were diagnosed and treated in a timely fashion, despite the pressures on the hospital from all of the COVID requirements. And then finally, to maintain a patient-centered and emotionally supportive treatment context in COVID. These missions, all three of them are things that remain with us till today. And we have had to make a variety of changes, again, facilitated by the urgency of the circumstance. And it went from changes, structural changes, physical changes to the Siegel Cancer Center, but mostly to the way that we worked. From the beginning, almost off the bat, we started Zoom meetings of all the Cancer Center employees, including clerical staff, nursing staff, physicians, surgeons, radiation oncologists, all of the technical people, information technology, and patient representatives. And this happened twice a week, so that in a sense, the family of the Siegel Cancer Center was brought even more closely. We very quickly, almost on the fly, I would say, moved into telemedicine, first talking to our patients by phone and then talking to them on other platforms that gave us a visual interaction. This turned out to be extremely important as we tried to protect the exposure of our patients by limiting the number of patients people that could accompany our patients into the clinic. We eventually started to see, notwithstanding these efforts, that some patients with cancer did develop COVID. And so we developed a virtual cancer COVID clinic where we had special nurses supporting these patients and speaking to them, along with psychosocial staff. Even though worldwide, all of the cancer clinical trials operations were shut down almost to a complete halt, we kept ours at our motor running at a slow pace. We did put patients onto clinical research trials that would help them in their fight against cancer. And so we rapidly ramped that up in the past few months. And we joined international collaborations, joining one of the largest consortium, putting together thousands of centers worldwide to accumulate hundreds of thousands of patients who had COVID with cancer to better understand how to treat patients and what the risks were. We made changes to our staff. Half of our staff, our clerical staff, stayed home while the other half was there, so that if some people went down, we always had a staff. We had to maintain a cold clinic, COVID cold clinic, and we did that in a variety of ways, again, on the fly, with screening techniques. We opened a special entrance just at the Siegel Center door on Legary so that only our cancer patients came through there. Early on, we were giving our patients masks, and our staff, again, was staggered so that the few patients that got sick, staff that got sick could quickly be replaced by people who were home. A difficult part of the challenge was for our patients that had to come to the clinic and could not be accompanied up by their family members. And that posed a very dramatic challenge as well. And organizations like Hope and Cope, with volunteers who, on the pretense of offering an orange juice or helping a patient to an examining room, end up sharing an intimacy with the patients. All of this physical contact had to go away and had to be replaced. And so we did a lot. We did a lot on the fly. And in the interim, in the past 2 months, we've been working very hard to get ahead in our surgeries, to get ahead in our screening, and to start to implement some of the technologies that we half implemented at the start, and now are trying to finally fully bring into the mission. I'll just show you 2 quick slides just to make the point of where we're at now. Next slide, please. First of all, the potential risk of isolating patients and dehumanizing care because patients couldn't be accompanied by their patients, or patients were afraid to come to the clinic, was a tremendous risk. And numerous studies now have linked social support to positive mental health. And additional studies have cited the negative emotional impact of loneliness. These are the issues that we're facing with COVID. As care providers, we strive to maintain that human connection with our patients, and we know that this betters our relationships, and as a result, our patients actually do better. Next slide. So in order to do that, we've had to apply new technologies, and you'll be hearing more about that from some of my colleagues. But on the left, you'll see Zoom, telephone calls, video calls, symptom management guidelines that are put on videos that patients could actually take home and replay, distress screening platforms that gave patients an opportunity to answer very targeted questions that we could respond to rather than waiting for the next appointment. And wearables, you'll see a good example soon, but where we could measure certain physiologic components of health and disease for a patient, even while they were home. And on the right, you'll see the top graph shows what typically doctors and nurses see. We see the patients and their medical outcomes, looking at x-rays and blood tests from visit to visit. But if you look at the bottom panel and you look at all of the different shades, those are the shades of what human life day to day is like. All the vicissitudes of living with care and living with fear and living with a fear of cancer and COVID. And so we're trying to capture that entire spectrum of the patient experience so that we can respond to all of that. I'm happy to answer all of your questions. I know this is very brief, but this is a beginning. Thank you.
Thank you, Dr. Battist. So many aspects, as you say, touching on the emotional and mental well-being of patients as well. And I'm sure that we will have many questions on that for you later on. But let's continue now with our next speaker. Dr. Lawrence Rudsky is the director of the Jewish General Hospital's Israeli Heart Center, or Azrieli, I should say, Heart Center. And he will be speaking to us now about COVID and heart disease.
Thank you, Caroline. If I can go to my first slide, please. And the next one. So COVID, you've all read in the press, and the early reports were that COVID had a very profound effect on the heart. The early reports from China suggested that up to 25% of patients with COVID had evidence of heart damage. But then we were faced with all these deluges of reports of what we call COVID science, where everything that happened seemed to be related to potentially, oh, it must be COVID, ignoring the fact that other things still happen in the face of COVID. So the evidence for heart disease from COVID is actually quite small. There was a big emphasis on myocarditis, which is inflammation of the heart muscle. But when you look at the total number of cases reported, it's not even in the dozens when you look worldwide. But there probably is an association, because when they do look at the heart, they can find evidence of the viral particles in the heart. There's also inflammation of the sac around the heart. And what we hear a lot of is something called takotsubo, or the broken heart syndrome, which happens both with COVID and without COVID. But because of the stress during the COVID era, the studies have shown actually a 5-fold increase in very strong emotional stress causing this transient heart damage. Most of the heart damage related to COVID is actually related to people who already have underlying heart disease. So when you do blood tests looking for enzymes of heart damage, it is quite frequently elevated, but it's not related to the COVID itself. It's just the fact that someone has a bad disease. And if you have a bad disease, a bad viral infection, and you have underlying heart disease, you'll see a little rise in your troponins, or the blood enzymes. COVID is associated with blood clots. That's irrefutable, and more evidence is coming along, but not necessarily blood clots in the heart. And when we look at heart rhythm disturbances, again, it's not nearly as prominent as had been suggested in the early literature. It's just people who come in, again, very sick for whatever reason, do get heart arrhythmias. When we look at the burden of serious heart disease related to COVID at the Jewish General Hospital, we've actually only had one patient, and that was only about a month ago, in a 23-year-old gentleman who was actually a medical student who was coming over from Africa and seemed to have caught COVID on the plane. And we've had 2 other patients who were hospitalized for COVID for other reasons, who had heart attacks while they're in the hospital. Next slide, please. So COVID really is a numbers game, and there's inadvertent heart damage. Across the world, when you look at advanced societies, there's a 50% reduction in the number of patients who present to the hospital with heart attacks, so huge drop, because patients are afraid to come to the hospital. And the problem with that is there's a doubling in your risk of dying because for the patients who actually came to the hospital, not because they got COVID, but because they came late. So we saw many late presentations of heart attacks because people were afraid to come. And when you present late, you end up with more complications. We measure in minutes the time that it takes from you to get chest pain or call urgence santé to get to the hospital. Our goal is to have the artery open, meaning you come to the hospital with the ambulance, you're gone through the emergency room, through the cath lab, and your artery is open within less than 90 minutes. We saw many people coming in 2 days, 3 days after their symptoms, and by then there was a lot of damage already done. What have we had to do to adapt? Our cath labs were not designed for viral pandemics, so they weren't what we call negative pressure. They don't suck all the air out very quickly. So we had to adapt how we ran our cath labs. We had to build this negative pressure chamber, and you can see the door being sucked in the lower panel. So we created this antechamber outside of our cath lab, which was a really novel design in order to make sure that everybody stayed safe. And we shared this design across North America. We saw a marked reduction in the number of angiograms we did, number of hospitalized patients. We had a time when our 54-bed unit was down to about 10 patients because everybody was afraid to come to the hospital. We had a complete shutdown of our cardiac surgery program for a number of weeks and about 75% reduction over a 3-month period. And we had marked reductions in our diagnostic testing and in our outpatient visits. And we had to, in order to create room for a second COVID intensive care unit, we had to move our patients and create a temporary cardiovascular intensive care unit, which really was with great partnership from our nursing colleagues and our nursing department, because without them, none of this could have happened. Next slide, please. We also led the COVID response. Not only were we the initial provincial hospital, but we led in knowledge translation. When the Heart Institute was designated as a COVID-free zone, they really didn't know how to set this up. So their chief of cardiology there, who I'm friends with, he called me and said, "Can you please share our protocols?" And their response was largely based on our information. We participated in a number of webinars, both in French with the Association des Cardiologues de Québec and across Canada, Canadian Cardiovascular Society, Canadian Society of Echocardiography, and we led a lot of these things. We shared our innovative designs, for example, our cath lab. One of our cardiologists was one of the clinical leads in the project, the genome project that Brent Richards discussed in the introductory film. And we also, as you can see to the right, I led an international manuscript to guide how we use imaging in patients exposed to COVID. Next slide. I also want to make an emphasis that one of the great things that we saw, as Dr. Battist alluded to, was people coming together and people stepping up. We had more than half of our cardiologists and cardiac surgeons work sometimes multiple weeks on the COVID wards, and I had the privilege of working as an orderly at Maimonides to give back to the system that has given out to my family. Next slide, please. And where's the future going? As Dr. Battist also alluded to, we've introduced these wearables. We're doing some interesting pilot studies right now using patches and watches. The patches will measure a whole bunch of different biometric patterns, and we can hopefully use this moving forward to try and create a hospital at home, or to prevent patients with chronic illnesses from presenting to the emergency room in such a late phase. So hopefully we'll be able to step in earlier. And then another project which I'm leading in the hospital, which is not specifically cardiology, is related to the Microsoft HoloLens. If we can click the link, please. So this is a project we're doing in partnership with an engineering company called Auger Group from Trois-Rivières. The HoloLens is a computer headset with a virtual reality built in. What it allows us to do is it allows us to have 2 people in the room with only 1 person physically present. So here we have a simulation. That's Dr. Moss, one of our cardiac surgeons who's trained on this, working with Dr. Baldry, one of our intensivists, and they're troubleshooting on a patient actor with COVID who's on a ventilator. And Dr. Baldry is guiding Dr. Moss how to use the ventilator, how to make adjustments to try and improve his care. He can upload into his field of view holographically X-rays. Dr. Moss can order using his fingers, typing in the air. And our next plan for this, which is really exciting, is to deploy this in one of our CHSLDs. And we're in late stages of designing the pilot. So hopefully it'll be ready within a few weeks, so that we can have this ready for a potential second wave to help us work in partnership in pairs on a COVID ward. So we've really had terrible tragedies during COVID, compounded with the insult of not being able to visit loved ones who've been in the hospital or mourn appropriately. But I want you to know that your JGH family really has learned from our experience, has taken up the challenge, and we're ready for whatever comes, not only as relates to COVID, but moving forward and taking this to the next level and moving beyond COVID. Thank you.
Thank you, Dr. Rutsky. Amazing to hear all the different techniques and things that you've been working on, necessity being the mother of invention, and how the Jewish General Hospital and your staff have adapted so well under such stressful circumstances. Thank you for that. Speaking of stress, I think that we've heard both the doctors now, Dr. Battist, director of the Jewish General Hospital's Siegel Cancer Center, and Dr. Rutsky address the stress of COVID And we'd like to look into that a little bit more deeply now with the psychiatrist in chief for the Jewish General Hospital, Dr. Carl Looper. Dr. Looper.
Thank you, Caroline. And it's great to meet you virtually and to be able to give this presentation. The first slide, please. So I'm going to talk about the mental health effects of the pandemic. It's something that we in the mental health field are beginning to call a parallel pandemic. Next slide. This is some information from the Mental Health Commission of Canada. And it sort of gives you a picture of the mental health of the country, which we could say was pre-pandemic. What you can see here is they report that 1 in 5, or about 20% of Canadians, experience a significant mental health problem in any given year. It is one of the most common reasons for work disability, and as you see, a great big cost to society. Next slide. You've heard about different curves, flattening the curve. And so what you see here is a representation of different trajectories. The first in purple is the COVID curve that we just experienced. After that, the green is a curve of people who might have missed out on acute care that might have been needed at the time. The third later on is the effect on chronic disease that could occur as resources are redirected towards the pandemic. But I want to talk about the fourth curve. It's the red one, which has a small latency. It is displaced a little bit from the first, but then has a very sustained effect. And you know, the latency, I can say, is what we experienced ourselves. Initially, there were fewer demands for mental health services, and that's a natural response that people have, is really to shore up all of their resources, coping skills and mechanisms to be able to respond to an acute stress. But then what you see is an exhaustion, you see sort of an exacerbation of pre-existing mental health problems, as well as the occurrence of new mental health problems as a result of the pandemic. And we have some experience with this from the SARS pandemic in 2003, which had outbreaks around the world, and 2 of the major centers were in Hong Kong and in Toronto. And the research from these 2 experiences showed that people who were closely involved, either affected by SARS or close to it, like healthcare workers, really had sustained mental health effects, anxiety from the fear of SARS, depression from the losses that occurred, as well as post-traumatic symptoms from being themselves exposed or witnessing traumatic events. Next slide. One way to look at the mental health effects is really looking at the different lifespan trajectory and the different developmental stages and what might be affected by the stress of a pandemic. And we experience this in our department because we provide services in child psychiatry, in youth mental health, adult psychiatric services, and geriatric psychiatry. So for children, if you think of the development of children, the initial stage is really one of attachment and a secure attachment. So what allows a child to then develop well on their own, develop autonomy, separate from their parents, is having a secure base. And that can be influenced by an acute stress, such as a pandemic, typically having its effect on parents. You know, another big issue is how children learn is really through play, through social or interpersonal interaction. And where that typically happens is at schools, at daycares, at play groups, which all have been kind of suspended for the last number of months. And so it's anticipated that there could be developmental effects of that gap. When we talk about youth mental health, this is really a period of transition where youth are influenced initially by their family, but then quickly by their peers. And then there is this need to develop their own identity, their own concept of their future, and their role in society in terms of work, in terms of intimate personal relationships. And there's likely to be significant effects at this age group. What we're wondering particularly about the return to school is with the virtual or remote learning, the children or the youth who have some difficulty engaging to begin with, will that lead to a greater rate of dropouts or sort of reduced potential in terms of what they can achieve in life? The other kind of effects that we have are really affecting the whole family group. There are a few major issues that are of concern, and one is of an increased risk of family violence. This is seen during recessions, during financial pressures, and it's already been identified as a major concern by global organizations such as the World Health Organization and the United Nations. The other issue for teenagers is the amount of time that they spend on social media and what kind of effects that could have. Although it can have benefits to allow them to continue their education remotely, it could also expose them to inappropriate content, but also cyberbullying, predators that can find their way on the internet. When we talk about adults, this is probably not news to you. You would probably have experienced a lot of this yourself. You know, fears of employment, loss of employment, financial insecurity. The whole family constellation loses support by having the less presence of grandparents and the whole family network. And the anxiety that adults would have about their parents, about their children. And to go to the possibly the most effective group being older adults, you know, we see a number of effects, some devastating and some less so, but still very significant. We are seeing now older adults who are deciding to end their careers earlier. We're hearing about this regarding teachers who might be fearful of returning to the classroom. We're seeing loss of productivity. And then the very real fear that this is the population who are most at risk of the medical outcomes of the coronavirus, as well as the social isolation, which we saw tragically in the long-term care facilities. Next slide. I'm just going to mention that on our radar has been some of the high-risk groups. These are essential workers like healthcare workers or frontline workers in the service industry, and as well people with pre-existing mental health or addictions problems, the homeless, people with neurodevelopmental problems like autism, neurocognitive problems like dementia. And these are all people who may not be able to protect themselves because either by virtue of their workplace, they're exposed, or because they live in group settings, supervised settings, they are then exposed to the virus, or possibly even having an impairment that doesn't even allow them to follow the usual protective kind of measures. And that actually is a risk for them. It's also a risk for society because there can be an endemic type of situation that develops. Next slide. So what was our response? So first of all, what I can tell you is that we realized that mental health was an essential service. It wasn't necessarily recognized that way by the government, by the ministry, but we knew that that would be the case ourselves. And we decided that we would have to maintain as much mental health services as possible. And this is what we did. And we did it largely through telehealth means. We were very lucky to have some members of our department who are themselves tech experts, rapidly converted our entire department to telehealth, both in terms of equipment and in terms of training. A lot of what we do can be done remotely. And so the few things that were shut down were the ones that were taking place in group. So it is a significant loss because group setting has very unique advantages. But we maintained all of the other services that we had. It also allowed some of our staff who themselves were older, maybe they had pre-existing health conditions, were at risk and not able to enter the hospital, they were still able to work from home. And so it kept our department productive. We also recognized that we had to bring services to people. And so we developed a home hospital service, which was staffed by a psychiatrist and about 5 healthcare professionals. And it was to deliver a kind of admission of hospital, but at home. They would visit the patient every day, even spending hours with them. The psychiatrist would be in touch to manage and modify the treatment. And what this allowed us to do was to primarily discharge patients earlier from our inpatient unit and make a better sort of use of our resources. Another project which was a great success was an outreach program for isolated seniors. And this was very unique because it was a volunteer program that was connected to healthcare professionals. So by this time, we now have over 90 volunteers that have been recruited and trained, and they were matched according to their skills to the referrals we had according to their needs. So people who had greater distress were matched with somebody who might have a background in mental health or have a lot of experience dealing with these issues. And they always had a clinician on call to them that they could consult with if ever there was a problem. We've had over 600 referrals, and currently about 250 clients are receiving this care weekly in an ongoing way. Lastly, I have to tell you that we had a very unique experience where we were mandated to convert to a COVID psychiatry unit. We have a 48-bed inpatient unit, and the region health authority decided that psychiatric patients who were COVID positive needed to be cohorted in one site in order to not contaminate all the inpatient departments. And so on a very short order, we had to convert to a completely COVID unit with all the modifications, procedures, protective measures that entails. And so that was a big learning experience for us. And now I'm glad to say that we were able to discharge our COVID patients. They recovered, and we're now back to our usual. So I'll go to the next slide. Our usual is actually quite an improvement. In fact, during all of this, we were able to open a brand new inpatient psychiatry unit. And this is particularly relevant to the pandemic because the difference that we have now is we have a very modern facility. As you can see, these are single-bedded rooms. There is now the appropriate number of bathrooms per patient, of cleaning facilities. This is really going to improve our ability to prevent and control infection transmission. As you can see, it's very spacious also. We can now organize our therapeutic activities with the social distancing measures that are required. And as well, it's just also very beautifully designed, as you can see, with a lot of natural light. There are murals with very uplifting images and really conducive to recovery of our patients. I also want to mention that this was largely in thanks to the foundation who were very much involved. This project would not have happened without the foundation. And not only that, it also was really, I have to credit the community. People like you who become involved, who are interested, who help us achieve what it is that we're doing now. So I want to thank you.
Thank you, Dr. Looper. So impressive. I think sometimes we got the impression early on in the pandemic that hospitals were really quiet. No one was visiting them. And we get to see and hear now from the three of you just how busy things were behind the scenes and the tremendous efforts that people made to go outside of their comfort zones to help people who could not reach the hospital. Let's go with, we have some questions here from the audience. I don't know who would like to take this one on, but I'll throw it out to, I guess, anyone who would like to answer it. I guess it's about infection. This is the question about the anti-mask movement that is growing now. Not so much here, I believe it's more in the US. Should there be more of an emphasis by the government placed on the importance of wearing masks to protect others? Does anyone want to handle that?
Well, I saw the question in the question, and it's a patient who has cancer who's concerned about this in particular. I can't answer the political question. To us, it all seems quite obvious. This is a very simple thing to do, and it's quite it's emerging increasingly as time goes on that this is a very effective way of protecting yourself. So I think the government should be pushing back on it. We should all politely be encouraging everyone around us to wear masks and distance socially, particularly people who have risk factors. For example, cancer patients, the person that asked this question, people with high blood pressure or diabetes.
Absolutely. I think we can all agree on that. I have a question here also about mental health on COVID patients who I guess have suffered greatly. Long hauler COVID patients, I believe, is what the questioner asks. People suffering from anxiety and depression. What do you think is the effect of COVID on these patients, Dr. Looper?
Well, this is a very important question. In fact, there's even possibly a direct effect of the virus. We've seen neuropsychiatric type syndromes develop in people who had acute infection, but that's probably a very small part of the mental health pandemic. But when you're talking about sort of long hauler, I'm assuming you're meaning people who really had quite a serious illness with COVID. Often they experience the ICU in a very traumatic way. It's really a life-threatening situation. And so there is this sort of post-traumatic type reaction that people can have. You know, and then after even during their recovery, there is really an absence of support that they would normally expect. So even in the hospital, visitors were banned. So it was, you know, really by telephone or by video conference, by Zoom or other FaceTime that people could talk to their loved ones. So there are many ways in which this can happen. And what we saw even from the data out of the SARS pandemic in Toronto was that about a third of people who were affected in that way had persisting stress or mental health problems.
That makes sense, absolutely. And we've heard of people who've been on ventilators for weeks and even months. So we can only imagine how fragile they must feel after undergoing such an experience. Here's another question from the audience. What is the current medical treatment for hospitalized COVID patients? Is there a standard treatment or does every patient differ?
Well, I don't think any of us have worked on the COVID floor, but I will make a best to answer this. So there are standard testing procedures, standard orders, and in medicine, you always try and standardize care as much as possible to set the minimums. And it's been shown that standardized care does improve outcomes while still maintaining the flexibility of individualization. So for the average patient, it's antipyretics, meaning make sure their fever doesn't go up. It's supportive care. Oxygen for the sicker people, so their oxygen level is checked relatively regularly. And if their oxygen level is low, then we introduce oxygen. There's no specific antivirals that are given at this point, particularly for the mild or moderately ill people. The sicker ones, what we've learned is at the beginning of the pandemic, the sick ones would be put on the ventilators relatively quickly. What we've learned is that putting someone on a ventilator isn't necessarily always the best way of doing it. It's not that they can't breathe, it's just that they can't get enough oxygen. So we've found that other technologies, something that actually goes into the nose, two cannulas that go into the nose that forces air at a higher velocity called optiflow, can deliver the oxygen more effectively without having to put somebody on the ventilator. The sickest of the people are put on the ventilator. They actually have to be positioned so they're what we call prone, so lying face down, which is also a very awkward position. and they need particular ventilation settings. And there are still some experimental medications that we hear about in the news, some that have been tried and have not panned out. Again, the COVID science issue, which have led to some serious retractions from the most reputable of journals. And on the same day, The Lancet and the New England Journal of Medicine, which are considered two of the top journals in the world, had to publish retractions of studies. So again, standardized care, oxygen, treating the fever, making sure the patient is hydrated, with the caveat that I did not work on a COVID floor, and I'm living vicariously through my colleagues.
But can I just...
All right. Go ahead.
I think it's important that our listeners understand that we're also very actively involved in all of the clinical trials that you're hearing about and reading about. And we have been from early on with some very new molecules that are targeting the virus, and also molecules that are toning down this hyperimmune reaction that you also must have been hearing about or reading about. And so I think one reassurance that we can give all of you is that the best care anywhere is care that's accessible as well at the Jewish General Hospital. We have all of those active clinical trials ongoing, and all of the novel molecules that look like they are working or have been shown to be of value are also available. We're in touch with Health Canada. We're in touch with all of the clinical trial groups worldwide.
Dr. Battis, let's stick with you for a second. We have another question here from a participant. Should cancer patients take the flu vaccine, and how will a COVID vaccine be prioritized for systemic, I guess, cancer patients? Or systematic, I guess the question is, will they be prioritized?
Right. Well, first of all, everyone should take their the influenza vaccine. And we usually give that to all of our cancer patients. Even if you're on active therapy, there should be no hesitation. The opposite, it would be very good to do that. Secondly, we don't know what the policy is going to be in terms of a COVID vaccine when it becomes available, but presumably the regime will include people at increased risk, and among the people at increased risk, as I said before, are people with cancer, particularly people on active anti-cancer therapy, particularly people with metastatic cancer. So I think following data, not just our data, but international data, this patient population will be somewhere high in the prioritization list.
I think we have time for maybe one or two more quick questions. Maybe this one over to you, Dr. Rudsky. You were talking about innovative designs in your labs. This question is, how will the technology that is being developed in response to COVID change how we care for patients in the future? Is there a technology that will revolutionize the field in the future?
Well, there's never a technology. Technology is built on technology. It's kind of like, if I can see further, it's because I stand on the shoulders of giants, that famous quote. But each incremental little piece adds to the puzzle. And as Dr. Battis said, and Dr. Looper, we've leapfrogged years ahead in just simple things like, if we were trying to get telemedicine going, and telemedicine is going to change how we practice medicine. Now we have to figure out, are we going to use it the way it is going to best serve the patients, or are we just going to use it? The exciting part that we were able to introduce really has been the introduction of, or the concept of saying, we're going to go ahead with the wearables. We're going to recognize, Dr. Rosenberg has this saying, this motto, care everywhere. So we're going to figure out, based on this COVID experiment, what we're going through, how to get these new technologies in, the wearables, the watches, the patches, and how to put it into the patient's houses, into their homes, and keep them in places that they're safer and more comfortable. The other piece of the equation, which I'm not an expert in, is the concept of vaccine development. We hear this on the news, how we've gone in 6 months, what usually takes several years to do. And we have now over 150 companies working on vaccines, including new messenger RNA vaccines, new technologies that we would have never applied. So like you said in your comments, necessity is the mother of invention. There are many inventions going on here. No one that's going to change, but many that are going to change how we're going to practice medicine.
Absolutely. I think we are just about out of time. Do we have time for one more question? I'm not sure if we do. Maybe a quick one. Dr. Looper, have you seen a change in the type of patient presenting in your department? And is there more demand for online services now as we're talking about telemedicine versus in-person for mental health?
Yeah, absolutely. When I was showing that mental health curve earlier, we're still on the incline of the mental health curve. And what we're seeing is more demands in our department, particularly for youth. Also for our trauma-focused therapy program. And so that is really in keeping with the sort of known effects out there. We're also getting a lot more demands for telehealth. In fact, at times it's hard to get people to come in person from the wait list, and they're insisting on telephone or Zoom assessments, which still is very appropriate, and we're happy to provide that.
Yeah, I think anecdotally I've heard that therapists have never been busier with COVID. It's a problem that even people who consider themselves to be mentally healthy are struggling with at times. I think that just about does our time for questions. So I'm going to thank you all, and I'm going to throw it back now to Bram.
Thank you very much, Caroline. I just want to, as we wrap up, I just want to thank all of our participants, our panelists tonight, Dr. Battis, Dr. Rutsky, Dr. Looper, and of course, Caroline Van Vlaardingen for moderating. And I want to thank all of you, all of the participants. We were over, at one point, we were over 260 participants. I want to thank you for your attendance and your interest today. And I also want to thank you for your past support of the Jewish General Hospital, as well as your future support. It really does mean a lot to us. Simply put, the JGH could not be the leader that it is, ranked the #1 hospital in Quebec and the #4 hospital in Canada by Newsweek magazine. And we couldn't achieve that without you and without your support. So merci encore de fond de cœur. Thank you for the bottom of our hearts for your support. And I wish you all an excellent evening. Thank you.